Okay, so when we're talking about nephrology in a pharm class, we're mainly going to be focusing on kind of the implications of kidney injury and changes in kidney function, how that's going to be affecting us. So we're going to talk a lot about like kidney injury. We're going to talk about drugs that can cause it. We're also going to talk about once a patient has kidney injury, what do you have to do with the medications that are on in order to avoid further issues, right? So further toxicities and things like that. So we're going to kind of focus on that from a big standpoint. We're going to look at kind of prevention, how we can try to avoid kidney injury if we can with like medications and things like that. The problem is like once kidney injury occurs, is there a lot you can do to kind of reverse it? Unlikely. A lot of cases, you kind of have to give the kidneys time to kind of fix themselves, or if not, then you may have to find other means in order to manage those patients. So, for instance, like what's one way if a patient had zero kidney function, what can I do for them? Yeah, so we'll talk about dialysis a little bit. That's important as well because dialysis really changes how you dose a lot of your medications, especially ones we'll talk about that have certain physiochemical properties to them that make them more likely pulled off by dialysis, right? So, for instance, if you have something like vancomycin or something like gentamicin, right? Those are common antibiotics that a lot of these patients are being put on when they come into the hospital, come to ICU. You have to take that into account. And so if you actually look on like your LexiComp and go down through your drug dosing, remember how there's a section that says, for renal adjustment, so based on creatinine clearance of X, Y, and Z. There's also usually a section if it's pertinent to the drug, if it's eliminated to the kidneys, we'll have a section about dialysis. And we'll actually have lots of different varieties of dialysis. They're on intermittent dialysis. They're on maybe Monday, Wednesday, Friday dialysis. This is how you should have to dose it. If they're on continuous renal replacement therapy or CRRT, this is how you have to dose it. And so again, there's lots of different varieties of dialysis. We'll talk about a few here, but I certainly won't go into too much detail there. But it can very drastically affect how you dose your medications. And so you have to address this on every single one of your patients that have renal issues. Otherwise, you can get yourself into some pretty big trouble there, right? Okay. So first, looking at acute kidney injury specifically, and I'm not going to get a lot into the diagnosis necessarily, but we'll talk about drug-induced causes. We'll talk about different varieties and how that's going to influence us and how we manage our medications. So usually, how can you tell if a patient has acute kidney injury? What are some things you're going to be looking for? Okay, so if you calculate their GFR, and again, what are we using to calculate our GFR? So yeah, so Cockcroft Galt uses it very commonly, but it factors in the serum creatinine, right? So again, we're monitoring our serum creatinine. That can be very useful. What else can we use to tell? Urine output could be a big one, right? So if you see a big drop in urine output, anything else? BUN can be useful as well. Again, if you see a big spike in your BUN and serum creatinine, which usually you find where? On your basic metabolic panel, right? So again, it's typically the labs you'd be monitoring for that sort of thing. Those are the big ones. Those are the big lab tests you can do or measurements you can do to kind of see, okay, what's going on with my patient's renal function. But again, which one do you think would have kind of the most immediate change? Like say all of a sudden I just stop all kidney function for my patient. What do you think is going to be the first one to change? Usually the urine output, that's going to be the biggest thing to take a hit initially, but because again, all things have a half-life in the blood, and so it takes time for creatinine to kind of reestablish its half-life as you change that to reestablish this new steady state. And so we'll look at some graphs of that a little bit later on, but things like urine output are very useful to look for kind of acute changes in renal function. Serum creatinine BUN can be very useful, especially for more kind of long-standing issues or things that have kind of developed over the course of a few days. But we do know that when these patients develop acute kidney injury, there's a lot of morbidity and mortality associated with it. And again, recognition is super key here because again, if you can identify and you can try to prevent it or prevent it from getting any worse in the first place, it's going to be you're doing a lot better for your patient because there's no good direct reversal in the majority of cases. So mainly what our goals here is we want to monitor their hemodynamic status because again, typically what do you think their fluid status does when they have acute kidney injury? It usually backs up, right? Because again, if they can't clear fluid, guess what? They're going to have edema, they're going to have blood pressure starting to go up, so hemodynamic status is going to change pretty dramatically there, especially depending on other comorbid conditions. We also want to minimize nephrotoxins, right? So again, these are just drugs that are going to be potentially dangerous to renal function. We've covered a lot of these already, but we're going to kind of bring it back and look at it in this context here. And if we can, we would like to discontinue offending agents, right? So if we can try to get rid of medications that may cause further kidney injury, that's great. Is that always possible? A lot of cases, no. So we have things like, if a patient has a really nasty, HSV encephalitis or something, we need to use an antiviral. We need to use acyclovir. That's nephrotoxic. But again, it's like, okay, well, I can either let this virus run rampant or I can potentially treat it and try to manage the kidney, sequelae there. So again, it's usually a balancing act. It's usually kind of a double-edged sword in a lot of cases, and you see this more commonly like in your really sick sort of ICU sort of patients, right? They're really medically complex patients that are presenting to the hospital. Again, blood pressure management is going to be important here. Usually, these patients will develop hypertension in a lot of cases. However, we'll see with the different varieties of kidney injury, we're going to see that may not always be the case, but we're going to manage blood pressure, manage their fluid balance, and then also electrolyte homeostasis. How do you think this changes with someone with acute kidney injury? Yeah, typically you're going to think more on the side of too many electrolytes floating around. So again, one of the big manifestations is hyperkalemia, right, which is too much potassium, right? So hyperkalemia is going to be a problem there, and which can lead to what sort of issues? Arrhythmias, yeah. So again, we worry a lot about having acute kidney injury causing hyperkalemia, especially in those who maybe have an acute on chronic kidney issue. So chronically their renal function is not great, and then they have an acute event on top of that, which causes them to knock them down even further. And their K starts to get up kind of dangerously high, especially if they have a history of arrhythmias. You can start to see how this gets kind of a snowball sort of effect there. So electrolytes are super important. We'll talk about not only the acute effects here, but later on we'll talk about more chronic electrolyte management. And that's you're gonna find is much more based on things like calcium and phosphorus homeostasis. That'll be really important for the chronic kidney disease we'll talk about later. Okay, so there's several different criteria you can use to kind of monitor for renal function and kind of to grade the acute kidney injury that the patient's developing. You're going to see that I'm not going to quiz you on this specifically. However, these are things you're going to be monitoring for anyway, and these can be giving you an idea of like, okay, well, just how severe is this kidney injury that's happening here? So again, here's like the Rifle criteria where they're looking at things like increases in serum creatinine. So usually you'll kind of figure out what your patient's baseline serum creatinine is, and again, what's kind of normal serum creatinine for like a typical adult patient. Around 1 would be typically pretty good. For like a kid though, like you'd want a lot less than that. So maybe like 0.6, somewhere around there. But like 1 for an adult, probably fine, right? For most cases, maybe a little bit lower, maybe a little bit higher. But but if you see an increase in that, say 1.5 times or a 50% increase in their serum creatinine, that should be a warning sign. That should tell you something's going on. They're holding on to more creatinine for some reason. It's probably due to the kidneys more often than not. What could be another reason the serum creatinine rises? Where do you produce serum creatinine? From muscle breakdown, right? So again, you can see that potentially if you have rhabdomyolysis, serum creatinine could also go up there as well. So that'd be one thing you want to consider. But then you're also looking at GFR, which we mentioned GFR is based off of not only the patient's serum creatinine, which is being affected here, but also their weight and their age as well. So again, there's other things you're going to be taking into account. And then also you're looking at urine output. Typically, if you can get greater than 0.5 mLs per kilo per hour, that's considered pretty good urine output for most adult patients. For kids, it's usually around 1. We'd like to see 1 or more. But if they're less than, say 0.5 for greater than 6 hours, that is again showing you there's some sort of sustained issue where they're having too little urine output. And again, urine output you want to measure kind of over several hour time period, because again, there's probably several hours where you're not producing a lot of urine, but it can also kind of change based on fluid intake and things like that. Again, greater than 6 hours. And you'll have greater, so that's just risk for kidney injury. And then you have the actual injury itself when your creatinine goes like 2 times higher. So you see it's just kind of worsening parameters here. And then obviously failures when the serum creatinine is probably bumped up pretty significantly there, 3 times what the baseline was. GFR has gone down greater than 75%, and they're anuric for greater than 12 hours. So again, those are pretty bad signs that, hey, the kidneys are just not really functioning almost at all at this point. And so at that point, we'll look at things like end-stage kidney disease where they're on renal replacement therapy for greater than 3 months. So again, there's different criteria, and I'll show you another one in a second here, but they're based off generally the same parameters. Here's the AKIN or the AKIN criteria, and again, very similar, looking at changes in serum creatinine, looking at urine output as well. And if you see RRT, that just means renal replacement therapy. Okay, so looking at the different varieties of kidney injury you can have here, it's kind of is similar, kind of parallels pneumonia, as you can see in patients. But basically, there's kind of acute community-acquired kidney injury, there's hospital-acquired, and then ICU-acquired. And you're going to find here this is much more likely to be, if you see acute kidney injury, a lot of it's related back to healthcare in a lot of cases. Usually when you're looking at the actual causes, this can, if you have a community-acquired acute kidney injury, usually it's pretty likely to be due to one thing you can point your finger to. However, in a lot of cases, like for more medically complex patients in the hospital, it tends to be multifactorial, right? So it could be related to the fact that they're on vasopressors like norepinephrine, plus they're on nephrotoxic antibiotics, plus they're on X, Y, and Z other things that can also affect their renal function. So usually it's multifactorial in the hospital. You're also going to find that a lot of drugs are related to causing acute kidney injury, right? So again, my mantra is typically fewer drugs the better, right? Even though it's job security for me, the more drugs we have, right? But again, typically for your patients, it's better to have fewer drugs. But a lot of times this can be related right back to the drugs you're using for those patients. And typically mortality goes up pretty significantly as you're getting more and more sick patients, more medically complex, more multifactorial issues that are going on here. So again, common risk factors when you're looking at community-acquired acute kidney injury, things like comorbid conditions. So what are some things that could cause kidney issues for, say, just a typical outpatient sort of person? What kind of comorbidities? Diabetes is a big one, right? So diabetic nephropathy, so you have kind of a chronic kidney injury going on over time, and then maybe you have something acute on top of that, like an illness or something that kind of knocks your kidney injury down, or knocks your kidney function down significantly, kind of acutely. That could be one thing you consider. Certainly elderly patients, sepsis, dehydration is a big one, infection, medications potentially, and this is important when we're looking at starting new medications for patients. You can sometimes have acute hits here. And again, we'll look at the different kind of pathophysiologies of these different kidney injuries a little bit later, but these are things to kind of keep in mind. And a lot of times for hospital related, these are going to be things due to things like volume depletion, right? So again, why do you think volume depletion leads to kidney injury? Yes, I have less flow going to the kidneys, and the kidneys, they're pretty metabolically active, right? So the kidneys need oxygen. So again, if you're having less blood flow going to the kidneys, you're going to find less oxygen being delivered. Acute kidney injury is a possibility there. So hypotension and volume depletion are going to be a big reason why people have acute kidney injuries. We'll talk about pre-intrinsic and post-renal or kidney injuries, and this is going to be a big cause for the pre-renal injuries that happen here. It's due to volume depletion, due to volume status being a problem here. Anyway, so again, things like low cardiac output, because again, you're not perfusing the kidneys as well. Nephrotoxic drugs, which we'll get into, and then things like radiocontrast dyes can also be important here as well. And so we'll talk about some ways we can get around that. And when I say radiocontrast dyes, what do I mean by that? Yeah, so things you'd be using like for imaging studies. So if you're sending your patient for like a CT scan or something like that, these are things you need to be considering. And again, are all imaging studies, are they done like on a normal schedule basis where I can kind of prepare for them like several days in advance? Not always. In some cases, you need like emergent scans where you need to use dyes, and so I need to take that patient's kidney status into account beforehand to make sure that I'm doing things like discontinuing medications that they shouldn't be on. If I need to do certain things like hydrate them appropriately. So these are things you have to consider when looking at contrast dyes. And again, it's very similar for the ICU. Typically, you just have sicker patients you're dealing with. You're more likely to see volume status issues and hypotension, et cetera. Because we mentioned, when you're hypotensive, body wants to send blood to where? The heart and the head, and so the kidneys can take a backseat to that. So that's again another big site for kidney injury to occur, because again the kidneys take a backseat. They're vital, but not going to be nearly as vital as your brain or your heart. Okay, so typically the management is going to be dictated by the whatever the responsible etiology is going to be here. So again, you have to kind of identify, is this more of a pre-renal sort of kidney injury? Is it more of an intrinsic damage actually done to the kidney itself, or is it going to be a post-renal issue? Typically, if this is going to be pre-renal, this means that we're having kind of decreased perfusion of the kidneys. You can have this occur transiently and not really cause any actual damage to the kidneys themselves. The tissue is normally fine. However, if you have sustained pre-renal issues, you're going to find that this can develop into an intrinsic kidney injury. And this is where you actually have structural damage being done to the cells themselves. And usually this is either due to like a toxic, like a medication causing actual direct damage to the renal parenchyma, or it could be due to ischemic issues, right? So if I'm hyperperfusing the kidneys for a while, I can eventually see less oxygen being delivered there. Ischemic injury does occur over time. This is a big problem we run into with like vasopressors, right? And I use vasopressors typically when? So like dopamine and norepi and epi. When do I use those drugs? My patient is hypotensive, right? So again, they're hypotensive, I want to get their blood pressure back up. That's a big cause for a lot of kidney injury that occurs there, because as I cause all this peripheral vasoconstriction, again, the kidney takes a backseat to that. And so again, it'll find decreased kidney flow. You're going to find issues with that. What other drugs do you think could cause decreased kidney flow? So any drugs that we talked about that can cause like acute kidney issues, mainly due to things like with those arterioles, either afferent or efferent. NSAIDs are a big one, right? So NSAIDs, on top of some of these other issues, can lead to acute kidney injuries, and it's mainly due to a prerenal issue. And why is that? Yes, we need the prostaglandins to keep that afferent arteriole open, right? Because efferent, think effervescent, think flowing away. So afferent arteriole has to remain open with prostaglandins. If I give an NSAID, especially for patients who have kind of long-standing kidney issues, those prostaglandins go away, that afferent arteriole is going to constrict. That can cause an acute decrease in renal perfusion. Acute kidney injury right there can occur. On the other side of that, the efferent arterioles, what can affect that? Aldosterone is one thing, but more primarily angiotensin 2, right? The sequel to angiotensin 1. Right, so angiotensin 2 can be another thing that can actually affect that pretty significantly. So you start someone on an ACE inhibitor, they can find an acute kidney injury that can occur based on the effects on the efferent arterioles. See how all this stuff's starting to come back a little bit? I mentioned this, and I hammer it so hard in the beginning, so that way you can dust off those cobwebs and I'll bring it together. Anyway, right, so those are things to consider. But what may deplete volume in the body, the intravascular volume? Diuretics. Diuretics are another big one, right? So people who are chronically on things like Lasix or other diuretics can see this issue as well. So again, lots of things that can affect kidney blood flow that can cause that sort of pre-renal kidney injury. And so if they're already dehydrated on top of that, you can see how this can kind of compound the issue. And again, when you have, say, someone who's coming in and they're septic and they're hypotensive, what's their temperature usually doing? They're usually hyperthermic, right? And what do you give for fever? You give NSAID, so that's again one of the things we're like, well, maybe I don't want to use an NSAID for this type of patient. Maybe I want to use something else instead, like what else can I use for fever? Tylenol, acetaminophen, right? So again, there could be a case where I say, well, this patient's at risk for kidney injury. Perhaps I want to use Tylenol instead of an NSAID, like ibuprofen, ketorolac, or Toradol. So again, these are considerations you have to make based on your patient's pre-existing conditions, based on, are they at risk for kidney injury? Maybe I want to use one drug that is going to be non-kidney active versus one that is going to affect kidney blood flow. So all things to consider here. So, and then also the post-renal, this is less common. You're going to run into this, but this is where things can cause like obstructions, either actual in the renal tubules themselves or maybe in some of the collecting apparatus. But typically it's going to be preventing kind of downstream flow of urine from the kidneys and cause kind of an outlet obstruction. So you can see things like causing like crystalluria. So things that are precipitating out in the renal tubules can be an issue here. Myoglobin does this as well if you have something like rhabdomyolysis. So again, little things to consider. This is probably the least clinically relevant one, but certainly these two right here are going to be really important. We're going to talk about the pre-renal and intrinsic kidney injuries. Okay. So again, looking at on the actual anatomy itself, so pre-renal injury is going to be affecting basically the renal artery typically, or basically preventing flow of blood, oxygen-rich blood getting to the kidneys themselves. And then usually intrinsic kidney injury, so this is where you're going to see things like glomerular injury or like interstitial injury, all going to be happening within the renal tubules. And then usually post-renal is going to be either happening, it can happen here in the bladder, in the urethra, in the ureters, anywhere along this area here can be post-renal acute kidney injuries that can happen here, right? So you can kind of remember where it's happening at, and by thinking about where the drugs are going to be having their effect, you can kind of intuit where or what type of kidney injury it's going to cause. So as we mentioned, NSAIDs typically going to cause a pre-renal, right? But if I said something that's causing direct damage to the renal tubules, you'd think it's more interstitial sort of kidney injury, right? Or an intrinsic kidney injury versus something that, say, maybe a medication I gave that worsened a patient's BPH and caused an outlet flow obstruction, post-renal, right? So again, these are all things you can kind of intuit out based on what the drug effects are going to be. And we'll look at more of these in detail in a minute here. Okay. So typically what you're going to be looking at, and again, this is just kind of different causes that you can see for these different types of kidney injuries. Again, we're going to mainly focus on the drug-induced causes in a lot of cases here, but certainly whenever you're managing these patients, obviously, the assessment is going to be super important here because you need to kind of figure out what's likely to have caused a kidney injury in the first place. So obviously, do your kind of full history there, physical exam, laboratory tests can be very useful here. So again, looking at different changes in not only your analysis, but like your basic metabolic panel and things like that can be very useful in helping you to determine kind of what the likely etiology is going to be here, right? I'm not going to get into things like renal imaging and biopsy, but certainly that is a component to it as well. A lot of times if you can identify the drug, it's going to be pretty apparent, pretty obvious in a lot of those cases. However, you may need kind of further medical management in addition to that. But certainly pre-renal, volume depletion is going to be a big thing here. So either the patient is bleeding out. So certainly, you know, if a patient was on warfarin, warfarin can cause bleeding, right? So again, if your patient was having pretty significant bleeding occurring there, causing intravascular depletion, guess what? Now they can have a pre-renal kidney injury. So again, lots of different varieties, different ways that this can occur. But again, a lot of it goes back down to the volume of blood flow getting to the kidney is going to be diminished in some way. Certainly GI losses, you have a lot of diarrhea, vomiting can be related to that. I'll talk about some different varieties of renal losses as well. Looking, and again, functionally here, you can see like NSAIDs, ACE inhibitors, ARBs can all be kind of affecting that pretty significantly. We already talked about why that is. Looking at intrinsic kidney injury, we're going to see that we're going to find more drugs here that can actually be directly nephrotoxic. So in some cases, some NSAIDs can cause some direct kidney injury. However, we're going to also find things like certain antibiotics. We're going to find contrast dyes can be causing a lot of actual damage to the renal cells themselves. And then looking at the post-renal side of things, nephrolithiasis is a big one. Certain drugs can actually help to worsen that. Other things like anticholinergic drugs, because how would an anticholinergic drug cause a post-renal kidney injury? What does anticholinergics do to urine flow? Typically inhibits it, right? You're going to expect to see urinary retention because you're inhibiting that detrusor muscle that can cause backflow. So again, you can kind of reason out why these different drugs are affecting the system in different ways here. All right, so any questions on first half? Oh yeah, the other thing I mentioned, my new baby is quite large for her age. Dr. O saw her and said, "Oh, she's like 8-9 months." I'm like, 3. You didn't hear that, baby. You didn't hear it. You're beautiful just the way you are. No. Anyway, okay. So any questions on the kidney stuff so far? All right. Because remember, this stuff's important. I'm not kidneying around. All right, so continuing on with our etiologies for community-acquired kidney injury, a lot of times this is related back to renal hypoperfusion. This is one of the more common reasons for it. A lot of it's due to things like volume depletion, due to GI losses, a lot of vomiting, a lot of diarrhea, just dehydration, the fact that they're just not taking in enough fluids. And when do you think this might occur more often in Florida? Summertime, right? So a lot of people are out there in the heat. They're not taking a lot of water. Volume depletion occurs very, very quickly in some more at-risk patients. But certainly things like sepsis can be involved here. And then we mentioned the medications like ACE inhibitors, ARBs, mainly causing more of a functional decrease of the amount of volume being handled by the kidneys, but also the diuretics as well, just causing actual volume depletion through the kidneys, right? So all of that is leading to basically less perfusion of the kidneys. Again, pre-renal can evolve into more intrinsic kidney injury due to the hypoxic injury that you're kind of causing, right? So again, if it's a transient issue, you're transiently dehydrated, we can tank you back up with IV fluids and things like that, and you're fine. However, if it's long-standing enough, they can run into more issues there. Obviously, the more kidney injury that's already kind of the more chronic issues they already have to begin with, the more likely they are to see this occur here. And then more frequently in the hospital, ICU related sort of kidney injury, you're going to find this is more intrinsic, right? So you're going to find a lot of like things like acute tubular necrosis, things like that. Certainly there are other reasons to have acute kidney injuries in the community, but these are the more common ones you're going to run into on a day-to-day basis. Okay, so you're going to find that the risk for acute kidney injury goes up, and again, this is only going to be compounded if you're adding on like nephrotoxic medications along with this. But certainly when it's a CKD, that stands for chronic kidney disease, right? So again, if you have things like older patients or they're developing like septic shock, things like that can all increase your risk for developing kidney injury. And certainly, we'll talk about the nephrotoxic medications they can influence this. We'll go into more detail on those a little bit later. But things like cancer, trauma, surgery, all these things are kind of putting you at a bigger risk for developing acute kidney injury. Even previous history of injury again kind of sets you up to have further injury to occur later on. So, as I mentioned, pre-renal typically is going to be hypoperfusion of that renal parenchyma. Again, with or without hypotension, it could just be a volume issue, or it could be related back to a blood pressure issue, right? So, if you're really hypotensive, you can have tons of fluids in you, but again, you're going to be trying to shuttle that fluid over to the heart and the head, or if you have cases where the fluid is kind of sitting around in the interstitium, right, and it's not really in the intravascular space, that can be an issue there as well. A lot of times you're going to be running into this like GI losses or hemorrhage. So again, in trauma, this can be a big deal as well. Certainly people who are using diuretics or maybe abusing diuretics. Why might someone abuse diuretics? Yeah, weight loss is a big one, right? So that can be one reason there. Certainly systemic vasodilation, most often due to things like sepsis. However, if someone had maybe too much of their blood pressure medication on board, so something like dihydropyridine, calcium channel blocker, or a beta blocker, or something like that, could cause hypotension, which can again lead to hypoperfusion of the kidney there, or potentially get things like renal artery occlusion, things like that. Usually drugs aren't going to be quite involved there. However, you can see those kind of compounding on one another, right? So again, usually these things can develop into multifactorial issues. So usually our compensatory responses here are usually pretty good to keep us out of trouble. In a lot of cases, we're going to have things like the sympathetic nervous system activates, things like the renin-angiotensin system is going to activate here, because again, that's our main thing that helps to regulate kidney blood flow is going to be that renin-angiotensin system, which makes sense because Ang2 we said is going to be working on that efferent arteriole to try to help to increase that back pressure and increase that filtration rate going on in the glomerulus. Antidiuretic hormone is going to be a big one. We'll talk about different issues of salt homeostasis a little bit later on, but antidiuretic hormone is really important because it normally does what? Yeah, holds on to more fluid, right? So again, if it's detecting the kidney's not getting enough fluid being filtered there, it's going to say, hey, let's go and hold on to more by giving antidiuretic hormone. That also stimulates what? Salt retention, but also stimulates the patient to do what? To drink, right? It stimulates thirst, right? So again, if you've ever seen someone who has SIADH or syndrome of inappropriate antidiuretic hormone, which we'll see a little bit later on, those are the thirstiest patients you'll ever see. They would probably sell their own mother in order to get a drink of Gatorade or something. Like, it's very, very interesting when you get to see that in those patients. But you're going to see increased thirst, sodium water retention. Again, a lot of that's related back to antidiuretic hormone. A lot of it's related back to things like aldosterone, the renin-angiotensin system. These are all things you'd expect to see, and we have kind of covered before in our different classes here. Again, these compensatory responses can only go so far, and at an eventual point, you're going to kind of overwhelm that system and eventually lead to this hyperperfusion of the kidney. So again, looking at the functional issues here, we talked about ACE inhibitors and ARBs. Again, you're going to more find that this can be compounded in patients who have things like heart failure, right? Who have kind of poor cardiac output. They may not be perfusing kidneys great to begin with. Add on top of this, something that's going to be decreasing that backflow pressure on the glomerulus by opening up that efferent arteriole. You can start to see how these things compound and snowball one another. With NSAIDs, patients who have chronic kidney disease who are really dependent on those prostaglandins to keep that afferent arteriole open, you add an NSAID on board, you can find a big sharp decrease in their kidney function abruptly there. Hypovolemia, though, can also be a big issue if you kind of add this on top of with an NSAID utilization. And then I mentioned the vasopressors. This is one of those big things where you have to be very careful with long-standing vasopressor use. You try to use these as short a period of time as you can because of that strong peripheral vasoconstriction that can occur here. You can see things like mesenteric ischemia. There's been gangrene, necrosis of the fingertips and toes and things like that. But the kidney here is going to be taking a hit as well because, again, the body's got preferences on where it wants to shuttle that blood. Kidneys are going to take a sort of a back seat. And in most cases, that pre-renal kidney injury is going to be reversible. However, you may find that like prolonged azotemia or that hypoperfusion, that hypoxic injury can lead into that more intrinsic sort of kidney injury. So, and again, how would I treat a pre-renal kidney injury? How do you think? Treat the problem, right? So again, if they are on, they start a new ACE inhibitor, I could do what? Yeah, or to just discontinue the drug altogether. I could do that. But what if it's related back to hypoperfusion, related back to, say, GI losses? Give them fluids. Yeah, we'll talk about fluids a little bit later on. But again, give them a healthy dose of fluids. Again, everyone feels a little bit better after a liter of normal saline. That's going to be no more true here than anywhere else. So again, fluids are going to be really important. Again, by taking out the patient, that's going to be able to help to increase that perfusion of the kidneys. That's usually going to be step number one. Obviously, discontinue the offending agent, but then give them some fluids. Okay, now dealing with more of the intrinsic kidney injuries, we're going to either have damage to the vasculature, the glomeruli, the tubules, interstitium. Any of these are potential targets here for injury. And so certainly we can see things like, emboli that can actually be dislodged and can cause an issue there within the tubules themselves. So things like, if you had aortic manipulations and you had something like a thrombus get broken loose there, it could be an issue. Typically, you're going to find that the smaller vessels can become occluded as well, but you may not see necessarily a lot of acute kidney injury directly related to this. However, you may find that there's kind of long-standing damage that can be done due to inflammation and whatnot. And you can see with accelerated hypertension, it can also compromise a lot of that blood flow. So again, too much pressure there can lead to injury being done, again, over a longer period of time. So usually renal vascular damage is not one of the big things we think about from a drug standpoint, but again, just kind of covering it in total, this is another issue you can run into. So glomerular damage usually going to be relatively rare. We'll talk about this more a little bit later on. Certainly you can see some autoimmune conditions that can cause glomerulonephritis, but we'll look at a few medications that can do this. However, most of the acute kidney injury due to most of the intrinsic acute kidney injury is due to acute tubular necrosis. About 85% of those cases are due to this. And this is where you're going to find where a lot of our drugs are going to be affecting this. You're going to find things like, tubular toxins like myoglobin. So if you have like muscle breakdown in rhabdo, you can see this. Hemoglobin, if you were having like say hemolysis of the blood cells, you can see this, things like that. And this is where our big agents like contrast agents. So again, if they have to go to get scanned for something, or aminoglycosides are going to be a big one as well. And when would you use aminoglycosides for a hospitalized patient? Obviously for infections, but what type of infection? Pseudomonas, and more broadly, gram-negative, right? So again, a lot of times when you're treating patients empirically for things like pneumonia or sepsis, guess what? You got to cover for gram-negatives, namely Pseudomonas is a big one. And so again, aminoglycosides get used very, very frequently. They're very good drugs. However, they are fraught with some dangers here, especially things like causing intrinsic kidney injury. So usually what you're going to find is an initial ischemic injury that can be caused, and again, this can be precipitated by a prerenal sort of kidney injury. Will cause necrosis and apoptosis of the cells there. It's going to have issues regulating fluid and electrolytes. So you can find a lot of issues with electrolyte imbalances, with fluid backing up. You can find lots of issues with that. And then you're going to be eventually finding that the urine flow is going to be obstructed by things like cellular debris potentially, and this will show up on your urinalysis. This is going to be one of the things you're looking for when you're looking for casts and things like that on your analysis. Also, you can find that you're going to have an impaired ability to concentrate the urine effectively. So you may have loss of things like sodium when you're having this occur, but they'll overall have a decreased urine output, which again we can measure pretty easily, and then reduced GFR will also be evident. And again, that takes some time in order to see that. Again, injury can be reversed in some cases, but it's going to take time. And usually, again, tincture time is going to be the best thing for those patients. The big thing is to identify whatever the inciting event was, try to resolve that, and then give the patient's time kidneys to kind of resolve on their own, if possible. Some injuries are not going to be reversible, but in some cases it is. So looking at some more interstitial damage, again, you see acute interstitial nephritis being one of the more common presentations of this. You can see certain infections do this, autoimmune conditions, but certain medications will do this as well. So we'll talk about causes for that a little bit later from the medication standpoint. Again, this is another one that can be pretty reversible if kind of treated promptly, and again, the offending agent is addressed. Okay, and then post-renal, very rare compared to the other causes here. So less than 5% of cases that are caused by post-renal kidney injury. And again, you can have pre-renal, intrinsic, post-renal. They can kind of overlap on one another in some cases, but usually what you're going to find is more of an issue of bladder outlet obstruction being one of the primary things. So yeah, like prostate cancer or BPH, that can be one of the big causes for that, generally due to things like physical impingement here. Now certainly we can see things like crystal deposition can be an issue. So like if you have oxalate crystals that are forming here, so you can sometimes see that with certain medications that are increasing calcium excretion. Like increasing calcium excretion, more likely to see that nephrolithiasis and those oxalate crystals to form there. And then drugs with poor urine solubility. You remember any drugs we talked about? Like you have to give it like bicarbonate in order to make sure they stay soluble. I think you said it. Yeah, methotrexate is a big one, right? So again, when we give methotrexate for, oh, you said it as well? Fantastic, good job. Yeah, so methotrexate is a big one. We have to give that, especially when we're giving like really big doses of that for cancer, like for some of our leukemic kids or something like that. We have to go with bicarbonate because that helps to keep it in solution by alkalizing the urine. Because again, what's one of the big places that we get rid of excess bicarb? The kidneys, right? Because again, we want to maintain our serum pH around where? 735, 745, right? So we have a pretty tight control on where we keep our pH. And normally things like CO2, where do you lose that? Usually in the lungs, right? So again, you're going to be breathing off CO2. However, to get rid of excess base, you get rid of that through the kidneys, right? So it's very easy to alkalinize the urine, and by giving sodium bicarb, we can do that along with things like methotrexate. You usually don't have to do it for like patients on smaller doses like rheumatoid arthritis. However, for like your cancer kids, we do that very frequently. Or if we have like an overdose or something, we would give bicarb, and that helps to increase the solubility and helps to get rid of it more quickly. But you can certainly see things like acyclovir is another one that can be potentially precipitating out. If we're causing increased uric acid excretion, that could be another one where you actually can cause that to precipitate out and be an issue, like in your gout patients, things like that. So there's lots of different causes for this, but again, pretty rare in comparison to a lot of the other causes we've already talked about. is another big thing, though. Chemotherapy-induced tumor lysis syndrome. You remember any drug we use for that? Sometimes we'll give them allopurinol kind of prophylactically to help prevent uric acid formation in some cases. Remember, there's that one drug called rasburicase that actually went and cleaved it directly. And so if you ever have someone like especially leukemic patients who are at risk for tumor lysis syndrome, and you see the uric acid starting to skyrocket, you can give them that drug, and that helps prevent the kidney issues that develop from the uric acid precipitating there in the kidneys. Okay, so as far as presentation goes, again, we're looking for changes in normal habits, so changes in frequency, changes in the actual characteristics of the urine itself. So again, if you see like tea-colored urine, is that a problem? Yes, I always hate those posts on websites where it's like fitness websites usually, and someone's like, oh, I just started working out really hard, I got a personal trainer, and they show this picture of their urine, is like, should I do something about this? And they're like, yeah, that looks like Coke, you should probably go to the hospital. I'm like, nah, I'll be good, I'll just drink some water. Nope, you should go to the hospital, please do so. Right, so again, you're checking for changes like that. Any other color changes that can happen to the urine? Anything can change it red? Or orangish? Rifampin can do it, certainly. Anything else? Yeah, for UTIs, it's azo. Yeah, azo is the brand name. Phenazopyridine is the generic for that. So again, that could be something cause orangish, reddish sort of discoloration of the urine. And again, that can be concerning if they don't know about it because they think it's blood potentially, right? So again, you have to be careful with that. Make sure people know when you're changing the urine color. Green. Yeah, I mentioned propofol, turn it green. Black. If it's black, you should be really concerned. I wouldn't want to see that. Blue. Is that dye I mentioned, methylene blue, used for methemoglobinemia, so that can turn to blue. So again, a little bit of trivia there. If you ever asked a question of like, what could change a urine this color, you may have an idea now. Anywho, so other things you can see. So like sudden weight gain, right? Because if they're holding on to more fluids because they're not peeing it out, guess what? They're going to have some weight gain there. You can see abdominal and flank pain. And then again, it's important to determine if this is an acute issue, and a chronic issue, or an acute on chronic issue. So you guys can kind of understand the difference between those. So acute really means what? Their kidney function prior to the event was normal, was healthy, right? And they have an acute inciting event that's causing kidney injury. Versus chronic, it's going to be long-standing issue there. But you can have patients with long-standing issues, they have an acute decrease in function. That's that acute on chronic. We see this a lot with like drug intoxication as well. We'll talk about that, where they can be on a drug chronically and they have like, say like an overdose on top of it or something, or a decrease in clearance. You'll have an acute on chronic sort of exposure. Same thing can happen here. And usually, inpatient is a lot easier to determine than outpatient. Why do you think that is? I can monitor their labs daily, right? What else? Urine output's going to be a lot easier to measure, right? Because again, if I just put a Foley in them, guess what? I can measure urine output very directly there. The little, infants, I can measure their diapers, things like that. So there's a lot easier ability to monitor for this rather than dealing with the outpatient side where they may not really have a good idea of how things have changed or how dramatically they may have changed. We have a lot of issues with this when we're doing urine output monitoring for a lot of patients on aminoglycosides on the inpatient side, because again, over at Nemours, we're doing a lot of teenagers like cystic fibrosis. And do you think that teenagers like to be especially adherent to your recommendations as a medical provider? No, they want to be rebellious and they don't want to say, hey, pee in this jug every time you have to go to the bathroom so we can monitor your urine output. Guess what? They either don't care or they don't want to, and they just pour it down the drain. They just don't think about it. So it can be problematic in some cases. So sometimes you're monitoring the number of voids they're having and not necessarily directly the urine output, right? So sometimes if you're saying, hey, at least this is consistent with what their normal is, they're peeing say 4 or 6 times a day, that's fine, right? Versus if it goes down to like 2 times a day, that could be indicative of something more problematic. Okay, obviously patient history, you want to check for any chronic conditions that may be affecting this, hypertension, diabetes, chronic kidney disease, anything like that. Medication history, especially for changes in medications, right? So again, if they had any new medications added on board, they've had any changes in dose, anything like that would be important to consider there. And then you're monitoring things like laboratory studies, obviously surgeries. And then the other big thing is going to be like OTC stuff, herbal medications, recreational drugs, because again, you may not really know what you're getting yourself into when you're taking any of these, and cause some issues there. So certainly, anyone know any like recreational drugs that could potentially cause kidney issues? You see this more with like amphetamines and a lot of like the stimulants, because again, if you have a lot of stimulants on board, cause very severe issues like rhabdomyolysis and hyperthermia and things like that. So we've seen some cases with some of these. Anyone heard of the drug Gravel or Flocka? Yeah, so at least heard of it ostensibly. It's actually a really nasty sort of like bath salts derivative, and there's some big issues where some people were taking this, and even just one-time dose, they're getting their temperatures up to like 106, 107 degrees Fahrenheit, having very severe muscle breakdown, and some of them actually had to end up going on dialysis due to the rhabdomyolysis they developed from that. So again, it can be very severe. But again, these are questions to ask. Illicit substances, herbal stuff, OTC stuff, anything like that, to get a full history for your patient. And then we don't know trends on laboratory data can be very important here as well. So again, it's good to know that, hey, your patient comes back with a creatinine of 1.2. But the question is that abnormal for the patient? So if you have access to previous labs to see, okay, what's their baseline normally? Is this different than what their baseline is? Is this worse, better? And then any kind of trends you can look for can be very useful in a lot of cases. Okay, so serum creatinine is good. However, there's several limitations to it. So we already mentioned some of those when we talked about the geriatric section. So what are those? Yeah, so low muscle mass, right? So in elderly patients, or say for instance, like an amputation, what's that going to do to your serum creatinine? It's going to be falsely low, right? And then that's going to help you to underestimate, overestimate renal function. You're going to overestimate what their actual renal function is. Because remember, if you're looking at that Cockcroft-Gault equation, remember serum creatinine was in the denominator. So that's falsely low. That's going to cause your creatinine clearance to be falsely elevated. So you think their renal function is better than what it actually is. Okay, so these are all things to consider. So you have a diabetic patient who has, bilateral below-the-knee amputations, but their creatinine comes back 0.8. I know that's not really the case, right? I know those long-standing diabetics are going to have bad kidney function, so that's something you have to take into account. A lot of elderly patients, I will go ahead if their creatinine is less than 1, so I think about like 80, 90-year-olds whose creatinine, whose serum creatinine is less than 1, I just round it up. Right, I just round up to 1 to at least make sure I'm trying to limit how much I'm overestimating that renal function there in those cases, right? So again, much of it varies based on gender as well. So typically, who has more muscle mass on a weight per weight basis, guys versus girls? Typically guys, where again, there's always exceptions to the rule, but typically that's how it goes. Your diet can be important here. So again, who do you think would have a bigger serum creatinine, a vegan versus, say, a complete carnivore? I probably fall more on the carnivore side of things, but who'd you expect? Probably the carnivore, right? Because again, they're taking in meat. So guess what? Meat is muscle. Meat has creatinine in it. So again, you can actually find that serum creatinine will be higher if they've had like a high protein meal, as later their diet is typically high in protein, versus if they were having very small amounts of protein, vegan, vegetarian. Not to say there's not non-meat sources of protein, but you get my drift here. So again, diet can be an issue here. Hydration. If they're dehydrated, what do you think that does to their serum creatinine? Typically it's going to bump it up. It's going to be more concentrated, right? So you have to consider, like, well, what's our hydration status? A lot of times what we'll do for our CF patients, when they come in, they typically, when they're coming in for a respiratory exacerbation, they're very dehydrated. And so we'll actually go ahead and give them several rounds of fluids, try to tank them up, and then we'll go ahead and check their creatinine and get a better sense of what the actual function is. Because again, with CF, you don't normally think the kidneys as being a problematic organ system, but you can see a falsely elevated serum creatinine and make kind of poor judgments on how to dose their drugs. So again, lots of little caveats here. Serum creatinine does take time to bump up behind the actual GFR changes, right? Because again, everything has a half-life, and how long does it take for something to get to steady state? 4 to 5 half-lives. So if serum creatinine all of a sudden has a longer half-life, it's going to take a little bit of time to get up to its new steady state. So if it normally rides at 0.8, and all of a sudden they have an acute kidney injury, it's going to take a couple of days for it to actually get to its new steady state, maybe 1.2 or 1.3. And we mentioned 1.5 increase in your serum creatinine could be indicative of kidney injury, right? That is high enough of a bump where you would want to be concerned with that. So anyway, so you have potential for late diagnosis due to this slow accumulation that happens there. And then be careful with the calculations. For instance, if I use the Cockcroft-Gault for an especially old patient, you may have some overestimations there. Make sure if you're dealing with peds, you're using pediatric specific equation. So for instance, we use what we call the Schwartz equation, which takes into account kids. And a lot of this is based off of studies where they look at a large sample population of a particular type of patient group, and they try to figure out, based on their creatinine measurements and based on their size and things like that, they'll figure out kind of what's the best equation to kind of fit that data to the model, right? So you remember model generation back in Epibio? I know you've probably tried to slash and burn all that information, but it comes back up every once in a while, especially with your research stuff coming up, right? Anyway, so again, just be careful, be aware of the kind of limitations in your calculus. And so looking at someone who had an acute kidney injury due to some acute insult, you can see the GFR, even though it has a pretty dramatic downturn in function immediately, you're going to find that creatinine does take time to really kind of get back up and reflect this new steady state. So that you have to be careful of. There's certainly other markers that people are looking at to get a better, quicker diagnosis. However, a lot of those are experimental, or we don't necessarily have available in the clinical setting. Serum creatinine and BUN are still going to be kind of your go-to things to monitor for those patients. And that's why we look at urine output in conjunction with serum creatinine. So even if their serum creatinine is still riding around normal, but their urine output has dropped pretty precipitously, that is still concerning for us, and we want to monitor for that. Okay, there's also changes you can look at in the urinalysis. I'm not going to get super in depth on this, but you guys will, I'm sure, learn this with Dr. O. You know what you're going to be looking for as far as like different casts and what that can be indicative of. But just know this can be another helpful tool in trying to guide us in deciding, what specifically is the issue with our patient's kidneys. One thing I do want to note here, and I use this pretty frequently in the emergency room setting, when you're looking at the BUN to serum creatinine ratio, typically this is a lot higher in the pre-renal case. So if I run into someone whose BUN is say greater than 20 times higher than the serum creatinine, that usually tells me they're pretty well dehydrated, and I know they need some fluids. So if I see that, I can usually say, well, let's give them some fluids, recheck the renal function, and then we can see what it actually looks like at that point, right? So that's one thing I look for pretty frequently. So obviously prevention is going to be the best thing here. So if we can prevent acute kidney injury, it's going to be way better than trying to play catch up and give the kidneys time to recuperate. So if it's predicted, we can potentially avoid it. So this is where we do things like aggressive hydration prior to surgery or prior to getting contrast by kind of making sure the intravascular space is very well repleted with fluid. It helps to prevent any kind of like hypoperfusion due to pre-renal issues, say bleeding due to surgery, or having contrast dyes, which we'll talk about a little bit later. Again, make sure they're just kind of on average taking a good amount of fluid intake, based on your patient. Obviously, someone like chronic kidney disease needs less fluid than someone who has good functioning kidneys, so that's something to consider there. And obviously, if we can avoid nephrotoxic meds, let's do that. Now, again, can we always get around that? Not necessarily. They need amine glycoside. They need amine glycoside. We have to go with that. But we can at least try to eliminate what we can. So for instance, if we can have a patient who is, septic and they're febrile, use something like Tylenol instead of using an NSAID for that. If we can eliminate at least one nephrotoxic med, we're at least doing our patient some sort of service there. And then obviously we like to be able to screen and identify those patients as best you can early on. And then that way you can do things like proactive drug dosing. So for instance, if I know my patient has really poor kidneys going into a situation, I can say, well, let's dose this drug differently rather than dosing it and then waiting for toxicity to occur and then changing the dose, right? So this can be very useful. Also, it's another way we can have a little bit more, say, reactive sort of changes in drug monitoring. Is there anything we can measure? So, yeah, it's usually like drug levels, right? So for instance, when I'm dosing amine glycosides for my patients, I'll look at their or like vancomycin is another big one where we do a lot of pharmacokinetic monitoring. I'll go ahead and I'll look at their renal function to begin with, and based on protocols, I'll say, okay, well, they have this creatinine clearance, their creatinine clearance is say 60. I know that I can dose, say, vancomycin Q12 hours for them at this dose, okay? So that's proactive, right, by looking at their renal function to begin with and go ahead and dosing it this way. And then based on levels, because again, every patient is a little bit different. As their levels come back, and I can say, oh, well, actually, they're not clearing as well as I thought they would, or they're clearing it more quickly than I would expect. Let me go ahead and change the dose on that point. So it's kind of a proactive period and then sort of a more reactive sort of period after you start to get things like drug levels back. And so when you work in a hospital, like aminoglycosides, vancomycin, those are two of the biggest ones you're going to do very frequent drug level monitoring on, and you're going to use as like kind of bread and butter, because for a lot of empiric coverage for different disease states, vancomycin and gentamicin are going to be kind of go-to drugs in a lot of cases, like pneumonias and sepsis and meningitis potentially, different things like that. Those are good go-to drugs. Anywho, so again, if we can implement any preventative strategy, we're going to try to do that. We'll see that a lot of cases like discontinuing drugs before a certain procedure is going to be one of the best things you can do, but we'll see there's a few drugs that maybe help spare the kidneys a little bit if you can't do that. Okay, so hydration is going to be the biggest thing that shows very consistently benefit in preventing acute kidney injury. So you can give them fluids, that's going to be best for them. Now, there's two main varieties of fluids. I don't know if I've mentioned this previously or not, but there's crystalloids and there's colloids. What's the difference between the two? Anyone know? Crystalloids is salts, right? So crystalloids are salts, basically. So that can include normal saline. That can also include things like lactated ringers. Anyone know where you use a lot of lactated ringers? Surgery. Have you started surgery yet? talk about that a little bit later, but there's a reason why they like lactated ringers. For those patients, it's a different salt sort of mixture, which I'm not going to get into in depth here. However, just know that that is mainly salt-based, and so it's considered a crystalloid. 9 times out of 10, probably 95 times out of 100, you're going to be using crystalloids for your patients, especially in cases they're dehydrated, you want to tank them up. This is the way we're going to do it. Colloids, on the other hand, tend to be more either starch-based or they tend to be more protein-based. So things like albumin. If you have someone who has low albumin levels, I can actually give them albumin, and that helps that. Because what's one of the big things that albumin does for us from a blood pressure standpoint? Yeah, so it provides colloidal pressure, or osmotic pressure, provides that ability to keep fluid within the actual vessels themselves. So patients who have poor albumin levels or low albumin levels are going to find they may be more leaky. They may be more leaking fluids outside of their vessels there, and that can affect your blood pressure. So in those cases, we can give things like albumin to replace that, and that will help to provide more oncotic pressure to try to pull more of that fluid in and keep their blood pressure stable. So you may see that being used occasionally. These tend to be more expensive, and there's also some issues, especially like some of the starches that tend to cause like bleeding risk and things like that. So these are not used as frequently, and in fact, some of these can actually be associated with renal dysfunction. So again, majority of the time, you're going to go with crystalloids. Go with the salts whenever you can. Now, if you have something like D5 with NS, that's still considered a crystalloid, because again, the main component there is that NS that's associated with that. Colloids used occasionally, but they're going to be much more patient and situation specific, rather than, I can use normal saline for everybody essentially. Okay, so why is 0.9% sodium chloride considered normal? Does anyone know why? Have I mentioned this before? Is isotonic, absolutely. So we're going to go through the math here real quick. Again, I'm not going to have you memorize this, but just know, and this is handy information to have, 0.9 grams of sodium chloride per 100 mLs, essentially is what that means when I say 0.9%. And so that equals out to be 154 milliequivalents per liter. And we mentioned that normal blood is, osmolarity is what? Like 280, 300, maybe 320, depending on what the situation is, but somewhere around 300. Okay, let's say on average. Well, if I mix 154 milliequivalents per liter of sodium plus 154 milliequivalents per liter of chloride, that equals that to be 308. Guess what? It's isotonic. We'll talk about this more in detail later on, but when I say something's isotonic, what does that mean for fluid shifting when it goes into the blood vessels? Stays right where it's supposed to be, right? It doesn't get leaked out into the tissues. It doesn't cause fluid to be drawn in. It stays just right there, right? So again, that's very good when you have someone who's intravascularly depleted. You can put all that fluid right there in the blood vessels, and it kind of likes to stay there essentially, which is good. So again, and also looking at normal serum sodium, usually in the neighborhood of 135 to 145, and we mentioned this is going to be 154. So what's a risk from giving too much normal saline? You can eventually see hypernatremia potentially, right? So again, it's not something we run into super commonly, because again, usually the kidneys are pretty good at being able to regulate that, but it could be a risk if someone had poor ability to concentrate salt, right? So if they're having like an intrinsic kidney injury. But typically, this is why we like to use normal saline. That's why we consider it normal, because it has it's isotonic to our blood, and it has roughly the same amount of serum sodium in it as our blood normally would have on most days. And then, for instance, you can give someone just D5 in water, but this is not going to provide that same sort of osmotic pressure as that salt would, because again, the dextrose is going to get metabolized and get pulled out to the tissues. And so because of that, I can give them D5 alone, but all that fluid is going to not stay in the vessels. It's going to be partitioning out into the tissues. So we'll talk about that more later, but just know that that's why we give normal saline, because it stays all in the intravascular space. Didn't think there'd be so much to normal saline, right? There's a method to our madness, why we do what we do in some cases. Now, some people try to do loop diuretics. What do you think? Why do you think loop diuretics could be potentially useful? What do you think the reason would be for preventing kidney injury? Because usually loop diuretics does what to the kidneys? Prevents salt reabsorption, right? Where does it work at in the renal tubule? Loop of Henle, which loop? Part of the loop? Not the loop of Don Henle either. The ascending loop of Henle, right? That's where that sodium countercurrent multiplier resides. That's where all that concentration happens. That's why loops are so potent, because that is where you're going to see the most concentration in the urine occur right there, by pulling all that salt in, essentially, right? So the thought is if I can increase urine blood flow, that's going to help to increase perfusion of the kidneys, and that's going to go ahead and help to prevent injury. Does that work in practice? Not really, because again, what can giving too many diuretics do to your fluid status? Can dehydrate you, right? Because again, if I pee out all my urine, guess what? My blood volume is going to go down. So not really found to be super useful. So we do not recommend doing that in most cases. Again, the other big thing you have to consider is that loop diuretics can also cause ototoxicity, which means what? Damage those hair cells, which can lead to hearing loss and things like that. So not to mention that some of our other drugs, it can also be ototoxic, things like aminoglycosides, things like potentially vancomycin. So these are other things you want to be careful with. Obviously if they're fluid overloaded, you got to get rid of the fluid somehow. Loops can be useful there, right? If CHF patient or something. However, not going to be good to help prevent a patient from developing kidney injury. If they've already got kidney injury, this is not going to help that in those cases. Even though the urine output may be down due to kidney injury, and you say, well, I gave him a loop diuretic and the urine output went up, and everything's fixed. Not really. You're not really dealing with the underlying issue there. You're just kind of treating one of the symptoms, right? And do you want to treat your symptoms or do you want to treat the patient? Probably the patient, right? In most cases. Okay, so in some cases we've tried things like vasodilators. They said, well, let's try to increase actual urine or blood flow going to the kidneys, and maybe that'll help perfusion out. So in some cases you may see like low dose dopamine being used here. And we said, where do we last see dopamine being used more commonly? As a vasopressor, right? So again, this is a very dose-dependent sort of effect. So if you ever see like really low dose dopamine, like 1 to 5 mics per kilo per minute, that's usually going to be used for its effects on the dopamine receptors in the kidney to help kind of increase perfusion. Again, maybe not found to be super useful because more often than not, we're using this as a vasopressor. And as you kind of bump up that dose, see more alpha constriction. That's going to actually help to diminish renal blood flow, if anything, right? Because again, all those peripheral tissues are going to take a back seat to the head and the heart. So not found to be super useful. We don't recommend that all the time, but maybe used occasionally. Another drug called phenoldiprate, which works on the dopamine receptors. Again, used occasionally, but no real consistent benefit to actually preventing kidney injury from occurring. Okay, so some people say, well, what if we try to prevent some of the hypoxic injury that occurs there by giving things like antioxidants, by doing things that's going to help to detoxify those free radicals that form when you have hypoxic injury occurring in the renal tubules. So some people would try things like ascorbic acid or vitamin C, right? So you can use that to help to detoxify a lot of those free radicals and maybe help to prevent kidney injury. Now, probably questionable efficacy. Hard to say, like, well, is this drug really going to be effective? Because again, can I, give half of you guys kidney injury, another half kidney injury, and then only give these people ascorbic acid and see who does better? No, you can't really do those studies. So again, a lot of this stuff is anecdotal. However, is vitamin C dangerous? Perhaps if I slug you with an orange in the head or something like that. But other than that, vitamin C is it's a water-soluble vitamin. You just pee it right out if you have too much of it. So really good safety profile, pretty low cost for the most part. So some people may try it, may not really see any benefit, but if it makes them feel better, I don't know, I guess, whatever. So I don't recommend this one very frequently. However, another thing we'll see here is N-acetylcysteine or mucomyst. Remember we saw that for Tylenol poisoning. This can actually be used as well because, again, it works as a good free radical scavenger. And so some people will use this prior to an inciting event. So I actually had we were dealing with a kid in the ICU who had chronic kidney injury, chronic kidney disease, who was on dialysis intermittently, but he really needed to have a scan with contrast. And so the nephrologist was coming in, they were kind of weighing the pros and cons. They really needed the contrast, but they knew it was going to affect his kidneys. Like, well, let's go ahead and recommend the N-acetylcysteine to give that. So we gave it to him for 48 hours beforehand and then for 24 hours afterwards. Try to make sure that any of the, actually it's backwards, so 24 hours beforehand, 48 hours afterwards. That's not important, but mainly the idea was to try to try to prevent any of those free radicals from causing further kidney injury by detoxifying them with the mucomyst. So again, who knows if it actually helped at all, but it's something we may try occasionally, so you may see that. Okay, the main thing though is going to be supportive care for these patients and trying to manage things like the fluid overload, trying to manage the electrolyte imbalance, so trying to manage all of that until you can kind of get rid of the causative agent. You can deal with the infection, deal with the drug that causes, whatever happens to be. In some cases, we may need things like renal replacement therapy, and there's lots of varieties. And I'm not going to get super in depth on this, but just know that like the more common ones we deal with is like intermittent dialysis, where you may have like chronic kidney patients who are on this like say Monday, Wednesday, Friday. They can be problematic because especially like from the ER setting, they miss their Friday session and then they come in like Sunday night and they're like a really dire straits because they haven't had it for a few days. We run that pretty commonly, but occasionally you may put a patient on intermittent dialysis for a period of time, and then when their kidneys have had time to kind of recover, then you can take them off of that and their function should be back. Again, depending on how bad the injury was in the first place, how much function they'll actually get back in those cases. But our main goals here when we're treating this is try to minimize the insult. So try to eliminate the offending agent if you can, reduce any of those extra renal complications, and then try to expedite that recovery there. So as I mentioned, dehydration is a big cost for a lot of pre-renal kidney injury, so I can go ahead and fix that by giving them more volume, right? So we mentioned normally we're going to use what? Normal saline, right? You're going to use a crystalloid. Typically, normal saline is the one you use most frequently. Or I mean, obviously, we can also use, if the patient can tolerate oral stuff, we can use PO fluids, right? That's going to be fine. A lot of cases, though, if you need really quick repletion, we're going to go with IV therapy, right? Typical dose, 20 mLs per kilo. Can't really go wrong with that. Typically for adults, 1 to 2 liters or so, right? Who should you be careful of giving a full fluid bolus to? CHF patients, right? They're already fluid overloaded. You can see this was like cirrhotic patients who have a lot of ascites. Those you want to be careful with as well. Who else? Potential cerebral edema. Probably not going to be as big of an issue there because it's more like kind of an acute problem. They can more have some long-standing issues, but this is like an acute, like fluid bolus sort of situation. Anyone who's got fluid overload, so if they have long-standing kidney issues, they can also be at risk as well. And what can I do in those cases? I can always give more fluids. I can't take it back necessarily unless I have like a dialysis machine set up on them already, right? So I can give like a half bolus in some cases. I can give like say 10 mLs per kilo, see how they respond, right? So monitor their blood pressure, monitor their heart rate, monitor things like urine output, and then based on that, I can potentially give more if I need to, right? Mainly our goal though is going to be to keep their MAP around 65 millimeters of mercury or higher. And what is MAP? The mean arterial pressure. Do you know how to measure that? I calculate that. I usually do the one where it's 1/3 of your systolic plus 2/3 of your diastolic, because again, usually you're about 1/3 of the time in systole and about 2/3 of your time in diastole. So I just add those two together. So 2/3 of your diastolic, 1/3 of your systolic, and that usually gives you your mean arterial pressure. It's on the monitors anyway for the most part, so you'll see that there. But usually 65 is what we shoot for. And then again, the urine output greater than half a ml per kilo per hour is generally considered sufficient for most adult patients. Obviously, looking for edema, listening to the lungs, looking for electrolyte disturbances. I like to make sure they're normal glycemic, so if I need to give some extra sugar in the fluids, I can do that as well. So these are all things you're monitoring for. Okay, so I mentioned you may need smaller volumes in anuric or oliguric patients. It's like 250, 500 mLs would be totally fine for them. You can always give more. And then in some cases though, like especially like you think like trauma patients, or you think patients who've had like really severe fluid depletion, like burns or massive bleeding, things like that. Giving too much NS can actually cause a hyperchloremic acidosis. So again, normal serum chloride is around what? Like 110-ish, 115-ish, somewhere around there. And we mentioned that normal saline has what concentration of chloride? So it's 154 for sodium, so then it means it's 154 for chloride. So again, that's a lot higher than what you would see with the ratio between the sodium, your normal serum sodium versus what's in the normal saline. So this is a lot higher. So you can actually run into hyperchloremic acidosis, and so that's one of those things where you may want to give it something with like a bicarb. So instead of using normal saline, I can use half normal saline, which is 0.45%, and just add in like sodium bicarbonate, and that can actually help to balance that out by alkalizing the blood a little bit. And then mentioned blood transfusions for anemic patients. Again, they need fluids, but obviously if they're anemic, you need to give them blood too, right? Because they need to be able to carry that oxygen. So that's always a thing there. What's another thing I have to consider giving whenever I'm giving blood? What electrolyte disturbance might I find? Not necessarily. So that would be if I was trying to stimulate erythropoiesis, right? We'll talk about chronic kidney disease and erythropoiesis a little bit later on. So remember, how do you keep that blood from clotting? Yeah, so you have citrate. Citrate anticoagulant actually prevents the blood from clotting off. So we'll see this in dialysis as well. But that citrate binds up calcium in the blood, so you may need to give calcium in order to replace that. So that's one thing you have to consider with massive transfusions. They'll usually end up getting calcium along with that. Okay, and then we mentioned the renal replacement therapy. Either intermittent, which means it'll be you get it for maybe 4 hours at a time, or it could be continuous in some cases. So if you ever see CRRT, that's continuous renal replacement therapy. Main indications you're going to see for this are going to be either I like to use the vowels to remember what my indications for dialysis are. So it could be acid-base abnormalities is A, electrolyte imbalance. This is very good for pulling off things like potassium, very good for helping to correct sodium a little bit, but potassium is one of the big ones you'll see there. Intoxications. So what type of drugs do you think are good for being pulled off by dialysis? Kind of the same things that make them good for renal excretion. So typically I like to see things that are very water soluble. Do you think you want them to have a very large molecule or a very small molecule? Because basically there's a dialysis filter that things have to partition across in order to be pulled off. Yeah, smaller is going to be better to get pulled off. Do you want something that's bound to protein or unbound? unbound, because if it's bound to protein, it's going to be stuck there on the protein. That doesn't get pulled off by dialysis. So these are like little things we consider. And so certain drugs like lithium is a really good one to pull off, right? That's just a normal metal ion, looks like sodium, that gets pulled off. We do that for things like aspirin. Aspirin's a very small water-soluble weak acid that gets pulled off very easily. So there's different intoxications we'll do this for. Toxic alcohols as well. So if you ever drink like radiator fluid, I can dialyze, you can get rid of that. But anyway, so intoxications is a good indication. Fluid overload, so and then if they have uremia are used. So again, that's kind of the main indications you'll see for dialysis in a lot of cases. Okay, so from the drug therapy standpoint, how you want to consider adjusting your patient's drug regimen is very important here. You need to really make sure you're doing good, thorough reviews of the medication list for your patients, especially like on the inpatient side, because they can be pretty dynamic and their renal function can change from day to day, some cases hour to hour, as it may be. But things you want to consider, what's the volume of distribution? How is this changing based on my patient's status, right? So again, if they're very edematous or acute kidney injury, they're volume overloaded, what do you think that does to like hydrophilic meds? Volume distribution is going to go up, right? Because again, there's more fluid for it to partition into. If they're dehydrated, maybe this stuff's going to start to concentrate in the blood more, and that can be affecting my drug levels. So again, antibiotics in septic patients is a very, very big challenge because again, the renal function is changing pretty dramatically. So not only are they hypotensive from the infection, but also they're going to be shunting blood away from the kidneys because they have vasopressors on board, like a norepi or something. And then I'm trying to dose their drugs to make sure they're not going to get nephrotoxicity from those as well. Can be pretty tough balancing act there, but that's why we do a lot of prospective drug monitoring for a lot of these. So, and again, no agent has any kind of benefit in actually treating the acute kidney injury. All we can try to do is prevention from a drug standpoint, and then try to manage the complications thereof. And you guys remember how we manage like hyperkalemia? C had big K drop, right? So C was calcium, A was albuterol. Terbutaline could also be used as well. We talked about that in the L&D section, but you can also use that as well. It's another beta-2 agonist. What else could I use? B is bicarb, right? So again, alkalizing the blood will shunt potassium into the cells. Insulin and glucose, right? So you have to make sure you're doing this together. If I just give insulin, what happens? Hypoglycemic, right? I don't want to do that. So insulin, glucose, and then D. K was what? K-oxalate, right? That's going to be a pretty slow process, but it's usually oral or rectal. You can give that. And then D was dialysis, right? That's kind of the end-all therapy. I actually pull that off. Most of the other stuff, except for the K-oxalate, is just driving stuff into the cells, and that's only kind of a temporary fix. And for these patients, especially like dialysis patients who miss a couple rounds of dialysis, they tend to have more of a total body overload of potassium. So shifting is good to kind of help prevent arrhythmia from occurring. However, you need dialysis to really get that off in the end. Okay. Some other things they've tried before. Has anyone ever heard of the drug mannitol? What do we use that for? Anyone know? That one we do use for cerebral edema. So anytime you're giving something very highly concentrated, very highly osmotic, what do you think that does to fluid? Does it draw it to it, or does it push fluid away? It draws water in, right? Because remember, things want to go from areas of high concentration to low concentration. So I have a very highly osmotic sort of agent in the blood vessels that's going to draw fluid into it. That's one thing you can do with cerebral edema. Again, too much fluid on the head, you can pull that off and decrease that pressure. You may see it being used there. That's probably the more common place we'll see that being used. We'll talk about it later, but we also use hypertonic saline quite frequently for that. So we mentioned 0.9% being normal saline. We can use like 3% saline. We can use 24% saline in some rare cases. That's some really scary stuff to play with because you can really kill someone with that stuff pretty easily. But it's good for trying to fix kind of an acute increase in intracerebral pressure there. But anyway, so sometimes we use mannitol as an osmotic diuretic, where basically the high osmolarity will help to draw fluid in, and that will eventually lead to further kidney flow and lead to further diuresis. Not great for preventing or treating acute kidney injury. In fact, it can actually cause it itself. But again, this is a good place I need to talk about it. You may see it being used in trauma centers quite frequently due to head injuries and increased intracerebral pressure there. So a lot of times we'll give it with like Lasix or something, and that'll help to kind of increase flow as well. One of the things to note with mannitol, if you ever see this, is very interesting, but it has to be filtered, right? Because this mannitol, it can actually go out of solution and will crystallize. So I think I have that on the next picture here. Yeah. So if you ever see this, and again, hospitals usually kept pretty warm, pretty cold. Pretty cold, right? Because we don't want bugs to grow, so we want to keep it pretty chilly. Bugs in a bacteria sense, and so this stuff will actually crystallize out. So if you ever see, like, especially in the pharmacies, they'll have this, or maybe in the ERs, they'll have like a little easy bake oven sort of thing, where that's their mannitol warmer. Basically, just like a box with a light on, so it's basically an easy bake oven. But is anyone familiar with easy bake ovens? Let me check my reference. Okay, good. Okay. Guys are like, what? But anywho, you can basically place this and keep it warm, so that way when you give it to your patient, it's hopefully in solution. If it looks like this, do I want to give that to my patient? No, because what could happen? Cause an embolus, right? I don't want that stuff to precipitate out in the blood and then cause issues there. Actually, one pharmacist told me a story. This is like back in the day before they had like mannitol warmers and stuff. It was at a trauma center, and then all the mannitols crystallized, and so they needed something to treat this patient. So he said, "Well, let me try to find some place to warm this up very quickly." And what do you think he went to? Yeah, he went to a microwave. So he went to the cafeteria and put it into a microwave. What do you think happens to glass containers when subjected to heat and increased pressure? They tend to explode. So he actually ended up destroying a microwave, and it's a little apocryphal. He said there's a big shard of glass like in his badge, and that was the only thing that protected him from dying. I don't think that was actually true, but however, I do believe he ruined a microwave. And so I said, from then on, no more microwaving mannitol. You can get yourself a little box to warm this stuff up. But anyway, you may see this. That was kind of interesting. Other loop diuretics, we mentioned furosemide is probably the more common one. What other loop diuretics do we have? We have torsemide, we have bumetanide, we have ethicrenic acid. Those are the main loop diuretics you're going to be seeing used. Usually ethicrenic acid you kind of save for patients with sulfa allergies, so you may see that done occasionally. Okay. Now, something you may actually find is that you develop what they call loop resistance in acute kidney injury. Remember the pathophysiology for that, or how they develop resistance to loop diuretic? So you're inhibiting salt reabsorption from the ascending loop of Henle. What's the next part of the kidney that it hits? The distal convoluted tubule, which can also reabsorb sodium. So usually that will kind of upregulate activity, and so that will start to increase that sodium retention, and it will kind of limit how good your loop diuretics are going to be. So that's called loop resistance, and you can see this pretty commonly in acute kidney injury. So what we'll do in those cases is either switch, if they're on oral, go to parenteral. It'll give them a little bit better bioavailability there. Increase the dose. Or in some cases, we'll actually do a continuous infusion. So you may see that being done continuously. You may see like 0.1 mg per kilo per hour, continuously or something like that. And then what we'll also do in some cases is actually add on something like a thiazide diuretic, and that'll help to limit that resistance there. You remember with loop diuretics, you can give it regardless of what the actual creatinine clearance is. Remember with thiazide diuretics, most of them lose efficacy less than 30 mLs a minute. Do you remember the one that doesn't, when you can continue to use in kidney failure? It's called metolazone. Or Zaroxon is the brand name. So you typically see it used in patients that have really poor creatinine clearance, usually less than 30 mLs a minute. And as a nephrologist one time told me, he said that stuff can make a rock pee. Okay, so again, think kidney dysfunction, that's a good thiazide to use for those patients, right? So anyway, we talked about the causes there, why that occurs. Okay, I mentioned chlorothiazide, metolazone, or Zaroxon. That's the main one we want to use in kidney dysfunction there. Potentially, you could use something that works in the collecting duct, so something like a potassium-sparing diuretic like triamterene or spironolactone. But more often than not, the thiazides are going to kind of get the best bang for your buck in those patients. Okay, so let's go ahead and cut it there. Any questions I can answer for you before we break? All right, well, hopefully everyone has to go to the bathroom now, and I'll see you guys next time.